This meeting is being recorded.
A very good afternoon, ladies and gentlemen. This is Dr. Harsh Chaturvedi. I represent medical affairs and clinical research of Pulse Pharmaceuticals and Pulse Nutritious. Welcome you to certainly a very topical discussion on nutritional challenges and MNT in dysphagia. Probably there's nothing, it wouldn't have been more relevant to be talking about it because we see that a large number of hospitalized patients, I am given to understand almost 15% of them, they experience dysphagia. And the dysphagia complicates the nutritional management, and also we know it contributes to a huge reduction in the quality of life of these individuals. So therefore, I also remember somewhere that reading that almost 45 to 50% of the patients in nursing homes who have been staying there for longer times, they also experience some degree of difficulty with their swallowing and those things. So having said that, we have Dr. Priyanka Rohtagi with us. We'll be talking to us with all of her experience and teaching us how to manage these patients who have the swallowing difficulties. And we also have Dr. Sreemathy with us, whom I have had the pleasure of knowing earlier also, and have seen her presentations and her deliberations. And Dr. Sreemathy, will be moderating today's session. With these words, I welcome you again on behalf of Pulse Pharmaceuticals and Pulse Nutritious. And I request Dr. Sreemathy to take over the session. It's over to you, Dr. Sreemathy. Thank you so much, ladies and gentlemen.
Thank you, Dr. Harsh. Welcome, Dr. Priyanka, and welcome to all the participants. Nice to see so many of them. June is Dysphagia Awareness Month. So I first like to thank Pulse Nutritious for hosting this webinar, and IAPEN India and Dysphagia Core Group is trying to do this awareness about dysphagia because June is Dysphagia Awareness Month. Dysphagia or difficulty in swallowing not only is there in clinical conditions, but also the Ministry of Health has also told in the National Program of the Care of the Elderly that in India, the Health Ministry has said that the geriatric population, which is 60 plus, will increase from 100 million in 2013 to 198 million in 2030. So the dysphagia, which is difficulty in swallowing, is not only there in clinical conditions, but it is also a hidden disability in the normal geriatric population, which goes underdiagnosed or not recognized at all. So I would first like to thank Dr. Priyanka Rohtagi, and she doesn't need introduction. She's very popular and very, knowledgeable about many clinical conditions, a very good friend. And I thank Priyanka for accepting this invite from IAPEN India to do this important session about dysphagia. So I would like to introduce Dr. Priyanka. Please show me the slide. Thank you. Yeah, Dr. Priyanka is Chief Clinical Dietitian and Head Apollo Hospitals, Bangalore. She was President IDA Bangalore Chapter 2011-2014. She's an elected member NEC between 2015 and 18. She has a PhD and PGCCM from XLRI. She's certified with European Society of Enteral Parental Nutrition and Metabolism, and she's done all these courses: onco, renal, critical care, gastro, body composition, perioperative nutrition, obesity, dyslipidemia, diabetes, and sports nutrition. She has 20 plus years in clinical dietetics and research. She is faculty for the online program Nutrition Quotient, an IDA-initiated program on weight management, has 8 gold medals to her credit, awarded with International Award from UK, Emerald Group for the best scientific work for the year 2007, Green Belt in Six Sigma certification, qualified trainer for 5S Japanese workplace management concept. She has done several research and contributed many articles, and she has more than 50 plus research publications in many scientific journals. It's always a pleasure to listen to Dr. Priyanka. Dr. Priyanka, please go ahead and talk to us about, share your knowledge, and we can ask all the questions at the end of the session. Please welcome Dr. Priyanka, and please go ahead. She's going to talk about nutritional challenges and MNT in dysphagia.
Great. Thank you so much, Sreemathy, for the wonderful introduction. And it's always a pleasure to be among the fellow companions and share your work, learn more from their experiences. So let's have the session a really interactive one. Today we are talking about a problem which is a real challenge for most of us, and this impacts our day-to-day working, because if the patient has dysphagia, our challenges are much beyond than just ensuring the diet planning. So I'll just take you through a little more than the diet in dysphagia. First, we'll understand what the problem is. As we understand from the name, dys means difficult, phagia means eat. So you can have difficulty in feeding in your patients at 3 stages, which could be oral, pharyngeal, and esophageal.
Priyanka,
So
sorry to interrupt. Can we see your slides? We are unable to see it.
You're not able to see the slides?
No, we are just seeing the desktop, different PPTs. Kindly share it.
I have already shared. I don't know what's the glitch. Are you not able to see?
No, we are not.
Let me try again. I'm sorry.
Please, yeah.
Binny, would you like to project the slides? I don't know what's the glitch.
Yes, ma'am. We will just give me a second. I'll do it.
So for people out here, IAPENindia.org, there is a website. You can all see the membership forms over there, and you can join IAPEN India. And also, if you want to be a part of the dysphagia core group, once you become an IAPEN India member, you can also see the dysphagia core group, all the details in the website, and you can contact the mail ID and be a part of the dysphagia core group. We are doing wonderful awareness sessions all over the country, so you can be a part of this important initiative and be a part of the dysphagia core group. Binny, is the slides ready to share? I think Priyanka has shared with us.
Are you able to see them now?
Yes, Priyanka, please go ahead.
Sure. So I was talking to you about the definition of dysphagia, where dys stands for difficult and phagia stands for difficulty in eating. So as we see in the picture here on the side.
Can you do slide share, please, Priyanka? We can only see your introductory slide. Can you do slide share and go to the third slide?
I am already there. I think there's some bug.
Now it's going. Now it's going. Can you go to the third slide? Yes. And full screen, please.
Are you able to see them now?
We are, but not in slideshow. So can you make it slideshow?
I am on slideshow. There's some glitch somewhere. I would request Binny to share then in that case. Let's not waste time.
Yeah.
Binny, could you please help out?
Yes, ma'am.
So we were talking about dysphagia, and there are various bodies which are talking about the guidelines. So initially, we were all dependent on the National Dysphagia Diet for giving us the outlines on how to, feed a patient with dysphagia. Now we also have much more in detail the latest guidelines which are available. So I'll take you through both the guidelines. But before that, there were few things which I thought would be interesting from a dietitian's perspective to understand in planning around the dysphagia, because many a times we may not have a speech therapist, a speech and swallow therapist in our setup, and lagging that, we can't really delay the feeding of the patient. So
Yes.
Yeah. So we were talking about what is dysphagia basically and how it's defined. Now the picture. No, no. Please go back to the third slide. Yeah, next to it. Yeah. Just hold on for a moment here. So we can see the windpipe and the food pipe, the esophagus as well as the windpipe. So when there is a normal feeding reflux, we would find that there's enough gap and the epiglottis is covering the flap very well. But in case of patients who have swallowing difficulties, you can see that there is a difference here and there is no clear cut coverage of the flap. So that's where you have a difficulty with the swallowing, which is also called as deglutition. And it takes extreme effort and time for the food to move in whatever consistency it is from the food from the mouth into the esophagus. Next slide, please. Now, when is it that we encounter this kind of a problem? We generally see it in patients who have Parkinson's disease. It's a progressive disease and the condition worsens as the disease advances. We also find it in multiple sclerosis, but here it is recoverable to a great extent. We may find it after a stroke. We may find it in patients with brain tumors, patients with dementia, patients with any kind of mouth ulcers, subsequent to which there is obstruction. There may also be a neurological condition where there's a damage in the brain and the nervous system over time, and that reflux reduces, so you find a swallowing difficulty. It's very prevalent in elderly population. And the biggest challenge is, if you see this flow chart down here, around 12 to 49% of such patients would be found in the hospital. But they can be managed because you have a team of experts there. But then there are the remaining 30 to 50% who are in the nursing homes who may not have all the specialists available. And 15% of them may be just in some rehab centers or at homes, and they really cannot identify the problem so well. And they come back to you in the hospital in a very bad aspirated state. Next slide, please. So what really happens? Let's understand the physiology of dysphagia. Dysphagia involves, swallowing involves a lot of parts of the body. There are 6 cranial nerves, there are 4 cervical nerves, and 30 pairs of muscles, which we can see. There are voluntary and involuntary neuromuscular contractions, and there are stages to the swallowing reflux. So in the oropharyngeal stage, we find difficulty in manipulating the food or liquid in the mouth. There's weakness in the tongue. The food cannot be propelled towards the throat efficiently. Such people can easily choke if the consistency of the food is very textured or it has chunks of food pieces. There is decreased ability to trigger the swallowing reflux. In case of esophageal, now here the entire condition is fine, but when the food is trying to get into the food pipe or the esophagus, we find that it is not able to pass well because the opening or at the top or the bottom of the esophagus is not cohesive enough to do that. There may be a dysfunction in peristalsis. Patients may feel that the food is stuck at some level. Next slide, please. Now, there are, 4 phases of normal swallow. I'll tell you this so that we can understand the abdominal phase very well. Now, when we have the oral preparatory, it includes everything around our mouth, our lips, teeth, palate, hard and soft, the cheeks, the floor of the mouth, the mandibles, and the tongue. They all would accept the food, hold the bolus in the mouth. We will chew it around, mixing the saliva into it, making into a nice paste-like consistency in the bolus form, which gets easily down. So this is a voluntary phase, which automatically happens because we are so used to this. If there is any problem here, say the tongue or the palate or the cheeks or the facial nerves, any of those have any kind of abnormality or compression, we would find a challenge in this phase. In the other involuntary phase, which is pharyngeal or esophagus, we see that the pharyngeal muscles, soft palate, epiglottis, these are all involved. They would take the food, try and push it down, and the larynx will make an effort to elevate the airway, the epiglottis, so that the food does not enter into the voice box or the larynx. Then it further goes down, and in the esophageal, swallowing reflux, we would find that it will pass easily through the peristaltic movement. Next slide, please. Common problems that we see could be any one of these phases. Your patient may be comfortable with the oral preparatory swallowing. There may be challenge in the pharynx. There may be challenge in the esophagus. So these are the 3 areas which, if we have some idea, can help us in resolving the problem. Next slide, please. Next slide, please. Yeah. Now, what are the risks that we would encounter? Would be aspiration pneumonia. 50% of our patients with dysphagia silently aspirate, and you could hear that kind of sound, and they would say that they are quite uncomfortable while they are eating food. Aspiration may occur in 43 to 54% of our patients who have stroke, and almost 40% of them develop pneumonia, and almost 4% of them may die of aspiration pneumonia if it's not diagnosed and managed properly. But by the time they come to the hospital, if they were managed at home or a nursing home, it's not easily identified. And when the temperature goes really high, that means that the aspirate has infected badly. That's when they land up into the hospital. By then, they have stopped eating. They are, very, very weak. The temperatures are high. The infection is all over the place, and it becomes quite difficult to manage them at that point of time. So we see malnourishment, undernourishment, and dehydration in them because they are finding something sitting here, so they have not been able to take any kind of food. It could be fluids or nutrients. There is inability to take required oral medications, and subsequently there could be fatal episodes. Next slide, please. Next slide, please. Yeah. So there are few things. If in your setup you do not have the nursing staff trained, or you don't have a speech and swallow therapist, let me just take you through. This requires a little training. So we identify the signs and symptoms of inability to swallow. If the patient says that I have slight pain while I'm swallowing water or trying to take a tablet or maybe a porridge, and the moment they try and keep the food in their mouth, they immediately cough out. So there's a gagging reflux when they try to swallow food. The voice may become a little hoarse. They may have a reflux of regurgitation. They may have a sensation of the food being stuck in the esophagus, or you might find saliva drooling out in and around their lips. These people, because of insufficient food intake, would classically show signs of weight loss, and this is basically muscle mass loss because this is not fat loss which is happening in them. And there would be acidity, which leads to frequent heartburn. Next slide, please. So how do we actually diagnose? There are diagnostic procedures. I'm sure all of us would not be involved here, but it's good to have a fair idea. So there is this barium swallow test. So barium is given, and then as you can see in the picture here, Slowly you can see how well it is getting passed in through the X-ray. There's also this dynamic swallowing study, or if the patient is going for endoscopy, endoscopically also it can be confirmed. If the patient is a cancer patient going for a PET scan, this also can be looked into through an MRI, CT scan, or a PET scan. Next slide, please. Next slide, please. Can you move? Yeah. Now, we need to understand that in India, still the situation is not so very stringent and streamlined. But if you look at the Western hospitals, there is a lot of preparation which needs to be done before these diagnostic procedures have to be put in place. Most of the corporate hospitals, because they comply to the NABH and the JCI protocols, they would take a legal consent for these procedures, explain to the patient what is the preparation around that, to the caregiver. If there is a need for any sedation that is given, generally it is given when the patient is well alert. Next slide, please. Now, the informed consent carries the mental competency of the patient to give a consent. The nurse must verify. There should be a witness around, and the patient should not have taken any kind of sedatives like opioids or benzenoids and sedatives. And she must advocate and support the patient in the decision that is best for his benefit. Next slide, please. Now, when they're preparing for this diagnostic procedure, there's a little workup which needs to be done the previous evening when they come to the hospital, a day prior when they come to the hospital. So we ask them to take a low fiber diet 2 to 3 days before the barium swallow test. Do not eat or smoke any form of narcotics after midnight before the examination. Prepare for the barium swallow test, wear the hospital gown, remove all kinds of metals, and clip or pin up the objects which are in metal in nature. Sign the consent form, ask your questions that you have to. We need to check if the patient is expecting mother, take the full history and go on. Next slide. So once this is done, there's a basic ABC which needs to be understood and explained. So we need to understand that there is aspiration which can happen. So the risk of aspiration has to be explained. Ineffective airway clearance. So it's always small amounts of the barium or any testing agent which is given, because we do not want sudden aspiration and coughing reflux. These people are liable to have imbalanced food intake. So we need to make sure that once we've done this and we are trying to build up the dysphagia diet, we have to make sure that it has to be micronutrient dense. We have the risk of unstable blood sugars owing to the unstable food intake. There is electrolyte imbalance which might fall in. And since we are not giving them a lot of direct fluid, there are chances that they may be slightly dehydrated. Next slide, please. Now I would like to take you through the interventions. So medications that are prescribed for treatment of dysphagia is dependent on the cause. If the cause of the reflux is certain medications, they need to be changed, or there has to be some PPIs which have to be prescribed. If caused by esophageal contraction, say there is a hiatal hernia around the esophagus, then some forms of calcium channel blockers are looked into so that the esophagus can be in a relaxed form. Patient may require per oral medications to be crushed really well or given via another route. The activities and the interventions needed, you may see a lot of these patients on the OPD basis, where you may not have a home care nurse or an attendant who is trained or has nursing background. So the attendant has to be explained that whenever you feed the patient has to be in a sitting position. Now, if it is an elderly lady who is unable to sit and has multiple sclerosis and is not really in the best of her posture to sit upright, a 30-degree elevation is also good enough. So 30, 45, maximum 90 degrees is what we tell, but 30 degrees is good enough for them to sit and eat. We need to tell them to chew the food slowly, take it piece by piece. I'll take you through the various stages of the feeding subsequently in the few slides coming next. We also look at smaller densities of meal. We look at the patient weight regularly. Now, many a times people come back and say that I think she's lost weight. We've not really checked her weight, but she really looks weak. And when you put her on the weighing scale, you realize that, oh, she's already 10 kilos down. And that's the time when you can't really recuperate overnight. So you really need a regular monitoring of the weight at every visit of the patient so that you have an idea that she is taking enough. Suction may be needed sometimes. There needs to be adequate care of the oral hygiene because they tend to hold the food and there can be bacterial contamination, plaque formation. And we need to maneuver certain practices like patients may just keep the food in the mouth and refuse to swallow. So we have to make them undergo the effortful swallowing, and there are certain other maneuverings which can be done. Next slide, please. Now, I'll just take you through briefly. These are few of the maneuvering. If you have a speech and swallowing therapist, they would actually know of all this. But if you're seeing this patient in an OPD and you do not have a therapist to refer to, a little idea on these will help. The effortful swallow is that collect all the saliva in the mouth, once onto the center of your tongue, keep the lips closed and together and pretend that you're swallowing a grape whole in one swallow. So you're teaching them how to take the food down in a bolus form. You can do multiple repeats so that the patient understands what you're aiming at. The Masako maneuver talks about stick the tongue out of the mouth between your front teeth and gently bite down to hold it in place. Swallow while keeping your tongue gently between the teeth. Let go of tongue between swallows and repeats. The third maneuvering is the Mendelssohn maneuvering, which talks about place the middle three fingers on your Adam's apple and swallow once to practice. Feel your Adam's apple slide upward, and as you're swallowing, you can see the movement. So these are few maneuvering exercises which helps us to appreciate the swallowing reflux. Next slide, please. Now, what should be the diet? Now, you would just get a blanket statement from the OT or from the ICU that semi-solid or mashed, but there's no clarity on what kind of food the patient will be able to tolerate. So we need to mechanically assess the texture of the food. It should be easy to swallow. It should not have any kind of choking reflux. So it should not be chunky in nature. Plus, we have to make sure that nutritionally it is adequate. So there are few options which were given by the National Dysphagia Diet. Let me take you through them. Next slide, please. Yeah, so they talk about the safety, the common terminology that the patient should understand, the age group specifications in all care settings and cultural variations. Next slide, please. So here we talk about the texture of the food to the patient, and this should be a part of the patient and family education, depending on the kind of age group that you're dealing with. Next slide, please. So now if you have to give them something like a fish or, nice boiled vegetables, or it could be a nice soft muffin or a cake, what we do is we churn it nicely. As you can see on the right hand side of the picture, everything is nice, thick, pureed. It's as good as scooping out an ice cream. So the first stage you can see is absolutely pasty, thick food. This would be called as the second stage of the food. The third is where you can appreciate the texture, but the texture is so soft that it would just go down easily. Next slide, please. Now, IDDSI is the recent guidelines, which is very, very practical for all of us to follow. These are evidence-based. These are nationally, internationally, and intraculturally valid. They have common languages. They are broadly supported, strong operational definitions, standardized foods and liquid testing methods, which makes it very, very simple and easy. They would give you measures in terms of spoon, fork, chopsticks, and syringes, and they highlight the relationship between the textures. Let's have a clear understanding of what they are. Next slide, please. So these are the terminologies in the framework. So before we move up to starting from the zero, that is thin, then slightly thick, then mildly thick, moderately thick, extremely thick, then we come to liquidized, pureed, minced and moist, soft and bite-sized, easy to chew and regular. So let's go at each one of them phase by phase to understand what they are. Next slide, please. So earlier, as I was telling you, we were following the NDD, that is National Dysphagia Diet, and now we've moved on to the IDD-SI. NDD was the only guideline that time available, but it was very generalized and subjective. However, IDD-SI was very specific and objective. NDD defined the texture in a very crude manner. So we actually did not understand the texture modification so well, and it would depend on each individual's understanding and interpretation of the image or the food. Whereas here, if you see the IDD-SI, it's very measurable, specific size modified textures, and it allows you to do a testing method and tool to evaluate the actual liquid and solid consistency. Next slide, please. Now let's go one by one. So what is thin consistency is something which is directly drinkable, like a coffee, a tea, milk, water, and juice. So you generally assess based on the maneuvers that we've done, whether the patient would aspirate or regurgitate on a thin, and we should avoid and give them a slightly thickened or a jelly-like texture. So based on that, they have defined the textures. Next slide, please. What is slightly thick would be some varieties of nutritional shakes. Like we take an oral nutritional supplement, which is thicker than milk, but thinner than a fruit milkshake. Something similar to a fruit nectar or an infant formula. Next slide, please. What is mildly thick would be a little thicker version of a mixie mashed oats porridge, or a little portion of curd rice mixed with a glass of buttermilk, churned well and filtered. That would be a mildly thick. Next slide, please. Then we have the moderately thick, something which you can drink from a cup or a spoon, like a nice soup which is creamy in its texture but not chunky. Next slide, please. So this is a small idea on comparing the levels of the feeding. This was a video. I'll try and see. Just see if you can play the video, Binny. There should be a... Okay, so this basically shows how when you put the liquid into a syringe and you try and see the drops, drop by drop, you can appreciate the thickness change in the different stages that we've discussed, which will tell us about, the clarity between the drink textures of the fluids. Next slide, please. We could go on the slide. Yeah. Now, what is this? Yeah. What would be a pureed or extremely thick consistency is, which does not require chewing, which is creamy enough to just go down. It is a smooth texture with no lumps, and it is not sticky in nature. Something like an ice cream, but not at that cold temperature. So an ice cream consistency, which is melting in the mouth and going down easily. Next slide, please. Next slide, please. Yeah. Now we can see that we are progressing a little more. So this is something which is minced and moist. If you give them something which is very dry, that again can be difficult to swallow. Like if we take small pieces of French fries and just piece it out, it's a dry item. But if we take a nice boiled carrot, mash it nicely, or a banana which is mashed nicely, or a stewed apple which is mashed nicely. It is chunky, but it is soft enough not to choke or block any part of the food. So this does not require biting. It has minimal chewing which is required, nicely mashed. You could pressure cook it, or you could just, with the pressure of a fork, it nicely mashes up. The particle size should be less than 4 millimeters for adults and less than 2 millimeters for children. Next slide, please. What would be soft bite size? The same food that we saw in the previous slide, but here the size of each particle is little bigger. You can appreciate that from 4 millimeters, now we are closer to 12 to 15 millimeters. Something which can easily be stuck into the fork and be eaten in one single bite. These are foods that can be mashed or broken down with pressure from a fork and requires a little moderate amount of chewing. For adults, the particle size should be lesser because the mouth size is smaller. Next slide, please. Now coming to the foods where we need to build up their protein. So we give them a nice cooked piece of fish, which if you try and eat from a spoon and try and mash it, it just melts in the mouth. Foods which do not, have any kind of choking reflux. Like if you're giving a chicken which has a bone, that can easily get stuck. But if it is an omelette or a pesarattu or a adai, which is soft enough to chew it down without any chunks of vegetables in it, it's easy to go, and this brings them the confidence of a little bit of chewing, but no choking that might happen. So this includes normal everyday foods which are soft and tender texture, and the size of the food particle need not be really restricted. It depends on the bite size of the patient. Next slide, please. And then comes our transitional foods, which are the foods with texture. They can change in another texture, specifically when moisture is applied or temperature changes. This again does not require biting, like pieces of boiled potato, which is just seasoned and given to them. So there's not enough chewing. Or you have small pieces of idli soaked in sambar, which again does not require a lot of chewing. So the tongue can be used to break these soft boiled foods, and once the temperature is altered or saliva is mixed into it, it becomes very easy to swallow them down. Next slide, please. So with this, we have a fair idea on the textures of our food. Now we also have standardized food testing methods using spoons, forks, and chopsticks. Let's have a look at them. Next slide, please. So as you can see, in the National Dysphagia Diet, we did not have so much clarity. It talked about just the pictures where you can see that there's a texture variation, but the size and the transition was not as good as it is in the IDD-SI. In the NDD diet, the fluidity was measured in terms of nectar-like, honey-like, spoon-thick. But when you see the IDD-SI video of the liquids filled in the syringe, you can beautifully appreciate and educate your patient attendants on how do you really want the dysphagia management in the patients. So these are very simple tools, need to be just administered and shown to the attendant so that they can accordingly implement. And if you do it this way, you have definitely very few, calls with doubts and problems that the patients are facing. Next slide, please. So basically, I would like to emphasize that we need to be, I know this is not a diet planning disease, but it is a disease where if the right education is not given to the patients and the caregivers, we might land up with a lot of difficulties that the patient comes back with, and we may not be able to then do justice to the case. So it's always worthwhile to spend that extra 10-15 minutes in educating the caregiver and the patient on breaking each food into small and frequent meals, avoid anything which has difficulty in swallowing. They would come back and say, I just had one popcorn because my grandson was eating it, or I just picked up a piece of khakra or chips or papad, and that itself does the damage. So they need to be really careful and not indulging into any of these textures. Food needs to be slowly eaten to avoid any kind of irritation and difficulty. And if the patient experiences any problem with thin fluids, we make it thicker. In India, we still do not have the jelly preparations available where you get a powder, mix it to any liquid and it becomes like a jelly. But we can still modify through the different cooking methods and ensure that we are able to reach the kind of thickness that we are aiming at. So with this, I think this is all I had to share with all of you. So you could, let's have some interactive questions. I just have some references. That's it. Thank you so much.
Thank you so much, Priyanka, for making us understand the different types of dysphagia and also the IDDSI and how it has been so important compared to the National Dysphagia Diet. I have one question for you first before I ask from the chat box. Temperature-wise, what do you think in your hospital setting? How does temperature help in difficulty in swallowing for a patient? In with regard to the texture, so if suppose you're giving a soft thing or a warm liquid, so will it help? What is your take on that from the practical experiences you have?
Practically, a slightly lukewarm temperature helps them to swallow things better. The colder or the chilled they are, it tends to sit and, we find it difficult for them to take it in.
Thank you.
So even if it's a curd rice, we tell them to add a little bit of warm milk to the made curd rice, nicely mash it. After we've mixie mashed it, we would just like to add a little bit of warm milk so that the temperature is not cold.
Okay, thank you. One more question from Prachi Chandra. What type of natural thickeners can be used to modify consistency?
Sweet potato, boiled sweet potato can be used in non-diabetics. And if it's a little texture, it wouldn't really make a lot of difference to the sugars. You could use rice flour to increase the consistency. Or boiled rice can be mashed into it. A boiled dal can be added to it. A nice boiled moong dal can be added to the liquids. And if you can add some ONS, that would also be good depending on the disease specification.
Fatima Malik is asking, can you please explain the different types of maneuvers in detail?
Should I go back to that slide?
Please, just can you, is it
Vinny,
possible? Vinny?
For all of us who have not visited the IDDSI website, it's really very conclusive, detailed with videos. So it brings about a lot of clarity in our, overall working. Please go up. Further up. Yeah. No. If you put it on the slideshow, I'll be able to tell you. Just go down. Yeah. Yes, this one. No, just go to the previous one. 2 slides previous to this. One more. One more previous slide, please. You've got, yeah. So we have the, no, go. You were at the right slide. You could just go back.
Backward. Ma'am, it's backward.
No. Ahead.
Effortless swallow. That one was there. Effortful swallow. That slide.
After
Yes.
this, yeah, this one. Just hold on to this. So we have different kinds of maneuvers to understand and explain to the patient. It would be nice that at the time of discharge, if we can show it to the patient with the attendant. So the effortful swallow is the patient is asked to collect the saliva in the mouth. Like, you tell a child to fill the mouth with water and then swallow a tablet. Something similar. So here we're not filling the mouth with the water. We just ask them to accumulate the saliva in the mouth at the center of the tongue. Keep the lips tight closed. Otherwise, you'll find it drooling all over. And then pretend to swallow as if you've taken a tablet or a grape or a pomegranate inside. So there's no food, but they're just swallowing the collected saliva down. This number of multiple repetitions will help them understand how we could collect everything, swallow it down in one gulp. The Masako maneuver is stick the tongue out of your mouth between the front teeth and gently bite down to hold it in place. Swallow while keeping your tongue gently between the teeth. Something like this. Let go of tongue between swallows and repeat. So once you've swallowed, then you let go the tongue, then again you hold it and then you repeat. Then you have the Mendelssohn maneuver, which talks about placing the tongue, place your middle 3 fingers on the Adam's apple. The Adam's apple is somewhere here, and then swallow once to practice. It might have a little, discomfort, as if, you're inducing vomit. But, when you try and do it, they understand the better control that they could easily, bring up the apple's Adam and swallow the food. So they find it much, much comfortable. This way, we are teaching them a little bit of maneuvering of the muscles so that the swallowing doesn't get obstructed.
Thank you so much for re-explaining that, Dr. Priyanka. Now, Arunima Banik is asking you, ma'am, kindly repeat the calcium channel line in case of patients having hiatal hernia.
Okay. See, what happens is if you know what is hiatal hernia, this is your esophagus, and there's a small pouch which is made here, which obstructs the esophagus to contract and expand for peristaltic movement. If they are those classic cases, the medical team member of your nutrition care process would prescribe them on a calcium channel blocker, which will help them in relaxing the esophagus muscle and allow them to eat the food well.
Sneha Agarwal is asking why we ask to stop smoking before barium test.
When you smoke, you are contracting the activity of your muscles around the tongue. So the efficiency would not be that great. The saliva secretion would be lesser, which we don't want.
Subhashini is asking, can nutritional supplements be given? If so, what nutrient-based nutritional supplements can be given to restore nutrition to patients suffering from dysphagia, along with soft foods, is what she wants to know.
See, if it's a diabetic patient and you want to add any of these disease-specific diabetic formulations, that can be added to your fruit custard, or if you're making a, moong dal payasam kind of a preparation. So a little bit of that to give that sweetness without adding sugar to it. So you're able to meet up your micronutrients and proteins. We find it very challenging in cancer patients. So what we do is we stew the apple very well. We put some supplement into it. So it becomes like a thick apple milkshake without milk in it, or a little bit of milk to maneuver the texture. But since their portions are so small, so it's very important that somehow, the supplement goes in to meet up the micronutrients.
Christilda is asking, what's the impact of temperature of the food? Having a lukewarm temperature has any advantage?
It's easy to swallow. Now, you can try it for yourself that if you are eating a khichdi, Christilda, if it's really cold, you find it very difficult, it becomes dry. So most of the rice preparations become thick and dry, and it's difficult to swallow. When they are slightly lukewarm, the texture is cohesive enough for you to swallow it down.
She's also asking, what's the role of ONS in such cases where we have to meet the RDA of the patient?
It is very important because because the consistency and the quantity is so less that, you're hardly able to meet up 50 or 60% of the requirement of that patient. We don't want them to lose weight just because of the swallowing reflux. So adding up to the ONS in whatever form you can would be a good add-on.
So some are asking for slides. So I just want to point out that this session is recorded and is available on the YouTube channel. So you can take down your notes and also the references. Manasa Penta, Dr. Priyanka is asking, can you please give any practical tips to improve hydration in those with the dysphagia?
You could give them things like popsicles. We take fruit juice or a fruit like aloe vera and put some things into it. and we freeze it and we bring it to a little temperature where it melts to some extent, and things which can be taken cold are taken. But if you have, things like khichdi, you are, feeding the patient and it becomes thick, so you'll have to add a little bit of buttermilk. Hydration is a big challenge in them because we don't really want to give them a lot of water because they can aspirate.
Sangeeta Rachor is asking, what about dementia patient? Is oral better or Riles tube feeds? Because patients are swallowing very slowly.
They're swallowing very slowly, they forget about it. So if you can, if there is a possibility and you've seen that they are just, having poor quality of life due to malnutrition, putting a tube is much better, and it makes your and the attendant's life easy.
And a lot of compliments for you, Dr. Priyanka. Very well deserved, beautifully explained. Subhashni is asking, is there any limit on water intake in these patients?
We don't really give a lot of frank water directly because we have chances of choking. So it is always in a little thicker consistency that it is given.
Yes, and I would also like to point out, if I may, Dr. Priyanka, that as an interdisciplinary team, it is very important for us to manage dysphagia, like when you pointed about the maneuver and all those things. So a speech language pathologist, yes, as you point out, in many people are not there, but a lot of awareness is happening. And there is a lot of interdisciplinary cohesive way this has to be done. So I think we need to raise awareness about dysphagia, and we as clinical dietitians should work closely with the physiotherapist. Why the physiotherapist is because the posture is very important. So would you like to comment about interdisciplinary teamwork, Priyanka, please?
We do it for the admitted patients, more frequently for the ICU patients. And this is really important because where you are stuck, the other team member can definitely help you. And it's always better to have a complete, aspect of the problem from all the disciplines. So it really helps.
Smita is asking, what is the reason easy consumption of semi-solid rather than water?
Water, when they are drinking, they might have a gag reflux and they might immediately, cough up and bring aspirate. So that's the reason in senior citizens, especially post-op or stroke, we do not really prefer giving free fluids to a great extent. Would you like to add anything here?
Yes, so in many neuro patients, the first thing that attenders try to give is, when we are not there, is a teaspoon
Coffee.
of water. Definitely, you should never give water to a neuro patient, because water is the most difficult to swallow, because as Priyanka pointed out, there is a more chance of them choking. If you see that there are a lot of cough, see, they cannot even swallow their own saliva. You can see when many stroke patients that how they drool the saliva, there might be, when you see that there will be multiple swallows of the same 1 spoon of food or the half teaspoon of whatever texture you're giving, there would be multiple swallows. So water is very difficult to swallow. So when the surgeon or the consultant or the intensivist says when that we can start trying, whether they do after fees or something like that, where endoscopically they are doing it. So it is very important to give a textured diet, as Dr. Priyanka said. Please do not start with water, but more of semi-solid or thick liquids. Honey, nectar, depends upon. So the SLP will also point out. So definitely do not give water to a patient, because it is very difficult to swallow, whether it is a neuro or a cancer patient with a surgery that has been happening. So there are a lot of feedbacks. Is there any specific exercise to control dysphagia? Tasmina is asking, Priyanka.
If you have a chest physio in your hospital, you would see them doing a lot of that. Since we are not really the experts, a little bit of maneuvering is what still is understandable, but I don't think we should venture into it because we are not
correct.
the experts.
So I just wanted to point out also, there are role of dietitian in dysphagia. There is clear guidelines that is there even from the American Dietetic Association. We are also trying to come up with some guidelines, but definitely please read out. The ITSI website, as Priyanka pointed out, has a lot of videos and good material. and the role of dietitian. So where we play a role, an important role, because as a teamwork, the main aim for the patient is to prevent malnutrition. So you can see the role of this dietitian in the dysphagia and interdisciplinary team is the most important. So a lot of compliments for you, Dr. Priyanka. So any other final words which you would like to tell, and then I would sum up.
I think we should venture out only when we are very confident and not just go by a gut feeling, discussing with your team members so that you don't risk anybody's life. And the literature is vast and it's available with videos. So if we just do more reading on the topic, we can definitely learn and, specialize in the area.
Thank you so much, Priyanka, for joining us today and really explaining step by step in different foods and how well the slides were so very interesting with colorful pictures. It really helped us to see the particle size of the dysphagic diet, and you also told in the Indian context setting where you gave us examples of our indigenous foods. Thank you so much. There is a YouTube link available and you can check out all these important points which Dr. Priyanka shared. Thank you so much for the wonderful response on this Dysphagia Awareness Month. And I think as clinical dietitians, we need to really give importance to this and learn of the guidelines and also try to do data collection so that Indian data can be available and we can move forward to help as an important part of the interdisciplinary team to manage dysphagia. I once again thank Dr. Priyanka for her valuable time and also for Pulse NutriScience for hosting this webinar. I'm Sreemathy Venkatraman signing off on behalf of IAPEN India and Dysphagia Core Group. Good evening all. Have a great weekend. Thank you.
Thank you.
Thank you, Priyanka. Thank you all.
Thank you so much, ma'am.
Thank you, Bini. Thank you to Pulse Academy for this wonderful opportunity.
Ma'am, thank you so much.
Thanks a lot, Ms. Priyanka, Ms. Sreemathy. Thanks a lot. And it was a wonderful, insightful session. Thank you very much.
Thank you, Mr. Ramesh.